Hello there, and welcome back to Yodo. I've got with me Laloma Legg. She's a licensed clinical social worker, and she gave us some time just a post ago, and I interviewed her about what it means to be a licensed clinical social worker. And if you missed that, basically it sounds like it's a lot of education, a lot of exams, and then you get some supervision before you get your license, and then you have a whole world of potential jobs that are available to you.
Yes.
And you shared with me a little bit about your personal journey that led you into hospice, and that your first real big paying full-time hospice LCSW job was with a community hospice agency.
Correct.
And that was with what I would call ambulatory patients. Would that be right?
Not necessarily. Always. Hospice service is for any patient that is facing an end-of-life situation. My second journey with another community hospice provider, the youngest person I had was 6 months old.
Oh my gosh.
And then the oldest I've had is 102. So
oh wow, full spectrum.
Exactly. And you have young people with life-limiting illnesses, whether it's cancer, you may have heart failure, those types of things. We've had people with traumatic brain injury, MS, just any number of diseases. So it's not age specific. It's not functional specific. Mm-hmm. Yes, I had a patient who he worked right up till his death. He didn't show up for work one day, and his supervisor called and
he passed away.
He had passed away in his home where he wanted to be. And so even having hospice doesn't mean that you
are bedfast.
You're bedfast, or you're slumped away into a corner and you're just going to shrivel up and die.
And so not all hospice patients are institutionalized.
That's correct.
So you went out to their homes to see them?
Yes. We did home visits, and I had one patient that we met. I worked out of downtown Orlando, and we met him under a bridge. He had one of the phones that were issued to make sure he was safe. He could have access to get support. And
who issued him the phone?
It was the state of Florida.
State of Florida
that had interventions with him and homeless programs right up until he had oxygen. Rather, he had to have oxygen. At that point, he could no longer be out on the streets and live in the streets. So, sometimes people choose homelessness. They choose it because of the journey that they've gone through life and things that society have put upon them, or things that they put upon themselves. But anyway, this gentleman was able to live right up until 2 weeks prior to his death. He got to the point where he needed oxygen, and then we were able to assist in getting him placed. And he had a clean bed and was comfortable right up to
the very
end.
end.
Yes,
and I have had patients that are homeless tell me that they choose that because of rules and money and freedom.
Mm-hmm. The freedom. And he didn't want anyone telling him when, how, what color. He wanted his freedom. And he happened to be a military member who had served an older era that when they came back, they were not received by our country as well as today's soldiers. And so he still harbored that resentment that he had done what he was ordered to do. And so that was his freedom, is the bottom line. So it's you see the patient wherever they call home, whether that's a nursing facility setting, an assisted living facility, a residential care home for adults, or their actual home.
Or private home. You had shared with us previously that when you initially started as a clinical social worker that you worked with kids, but you identified early on because of your heart that was a really difficult thing for you to do. And in a camp setting, you became acquainted with hospice.
Correct.
And that it called you to go to hospice.
Yes.
So from finding that, hey, I like this area of social work, to actually getting employed, how do you find a job as a licensed clinical social worker?
Well, you make connections throughout your education, throughout your internships, and what better time to make mistakes?
They do happen.
They do happen during your internship, but having an experienced clinician view you working with a client, help you to identify your strengths, your weakness, along the way is one of the ways that you can identify where should I go in social work. For me, I had, what I did omit earlier, I believe, is in my bachelor's degree, I had interviewed with a specialty program with Department of Children and Families, and when I got to that internship, the staff member that I had interviewed with had received a promotion, so the new person onboarding didn't feel comfortable. There were two of us that were supposed to be interns under her, working under her. She didn't feel comfortable entering into a new position and having interns. So like 2 weeks before my classes start, I am left with, oh my God, I have to have an internship. Where do I go? Wow. Well, guess what was the only one left? Bereavement services with hospice. And you know, again, I went in kicking and screaming like, I don't want to do this. But along the way, in healing others and supporting others in their grief, it was the bereavement department that I worked in, I found myself healing myself from losses that I had had, and being able to identify and work through, because I had walked through loss, I was able to support others. And so that was something that, but I still didn't take the bait and recognize. I still felt like I wanted to work with children. So when I went for my master's degree, which was a 1-year advanced program, that's where I identified that, no.
What's the difference between a social worker then and a bereavement person?
So bereavement person is helping the bereaved, which means they've lost a loved one, to cope with life without that loved one. And how do they go on? How do they focus on the positives? What resources do they have, linking them with maybe another bereaved person to help them learn how to go on? Because death, it doesn't just, it happens, you're going to get over it. No, that's a fallacy. You become a different person with that death. You become a different person coping with that loss, and you evolve. Over time, the pain may subside that was fresh from that wound of loss, and you may be able to be more capable of focusing on the journey that led to that loss, the love of that person, the life you led with them, versus the 6 month, 8 months that the end of life came for that person. Some of these bereavement coordinators are not just working with hospice. There's a whole field dedicated for bereavement support.
They're are they like more specialized?
Very specialized.
Okay, they just do that.
LCSW.
They don't coordinate all those other services.
That's correct. Their focus is either group or individualized therapy in supporting that person through that loss and learning how to move forward and continue to be a functional member of society.
So community hospice is probably going to have a bereavement
They do.
Social worker. And they're probably going to have the licensed clinical social worker.
The field social worker who's dealing with anticipatory grief. You're anticipating the loss. And during the treatment for a hospice social worker, you're teaching the family or supporting the family in learning those new roles that loved one used to perform that now physically, because of their illness, cannot perform. You're helping that patient cope with the loss of my roles. And how can I still be a functional member of the family, and how can I still add to the family, the central family unit, without doing those roles as it sounds like you're working. You're not just working with the patient, but you're actually working with the patient and every one of their loved ones. Correct. Yeah, so you're supporting them through this loss and anticipating each change and role as they go along right up to the death.
So the social worker for community hospice is to help the patient, help the family with the changes that are occurring, help them get in touch with...
Link them with resources.
Resources that they need. What kinds of resources? I know you had mentioned like...
For nutrition and caregiving services, because hospice does not do caregiving. Hospice is not performing.
Is it a staying service?
No, it's a visiting service. It does not perform custodial care. They are available 365 days a year, via phone, their triage line, but they do not perform custodial care, which is that round-the-clock caregiving. So linking patients and families with resources for caregiving. If a patient family member has to work, as I mentioned, we have younger and younger patients that person has to work. We try to link them with either church resources or age-appropriate resources that are available for help with caregiving, or private pay resources, to get them the support they need and assistance in the home. Things like help, I've fallen, I can't get up, the monitoring system, those can be resourced out. And then, if needed, we assist with placement.
So counseling and service coordination.
Yes, ma'am.
And then working with who? When you were in the community with a community hospice agency, who did you deal with? Who were the other people that you...
Within the team? The hospice agency, the team is comprised of a medical director who's providing oversight for that patient's end-of-life comfort measures and care. You have an RN who's kind of like the central cog of a wheel, who delegates what other services or is able to initiate other services as the patient indicates they need them. But that person is the one who's the main person available for addressing symptom management, the weekly visits or every 2-week visits. They may have a licensed practical nurse that works under the RN to do intermittent visits. You have a home health aide or a CNA certified nursing aide to help with personal care, activities of daily living, things like bathing, showering, shaving, tidying up their linens in their bed, maybe even making a small meal. But then you have the social worker to link with resources to address emotional support needs, link with the resources in the community, but within the hospice agency as well. And then you have a chaplain for spiritual support, and they work more like a military chaplain in that they do have their own religious affiliation, but they're not impressing their own religious beliefs on the patient and the family. They're there to guide them through the spiritual side of loss and to help them to plan ahead, and again also link them with resources. And then of course we had a volunteers department, which is part of the conditions of participation through Medicare. And the volunteer department, they may be someone who could assist with lawn care, or someone who could just sit with the patient so that the caregiver could go and do errands, grocery shopping, whatever, to make sure that there's an extra set of eyes and ears, but they do no hands-on care with that patient. And then the after-hours staff is a set of triage nurses trained to address crises in the middle of the night. You have a aligned team, but also if the patient needs to be seen, they'll dispatch a nurse to the home.
What a great service. So,
yes.
So it's the social worker and the bereavement person and a spiritual chaplain and doctors and nurses and aides.
And volunteer services, the intake department. You even have a finance department, so that I mentioned earlier, you have patients that have to go into an inpatient setting because of, say, the caregiver having to work, or they may be, I've had many patients who are the last member of their family, or they're estranged from family. They have no one to help care for them, so they need inpatient setting, whether it's an assisted living facility or a skilled nursing facility, long-term placement. You have staff in the hospice office who are working with billing, working with finance, who assist with applications such as Medicaid, institutional care, to get that person the services they need.
So you've done social work for hospice agencies in a community setting, and then you've also done hospice work as a social worker in a hospital setting. Do you find a lot of difference or a lot of similarities there?
So actually I've done palliative care services, palliative care coordination, and hospice coordination in a hospital setting. My prior position, I worked with a community hospital as the palliative care coordinator. My role was to get in. We would get our referrals from critical care, from neuro, from oncology, any number of
patients that are in crisis in a
hospital setting, and
they're hoping to discharge to another setting.
Exactly. And their primary role, I wasn't a discharge planner. I was a palliative care social worker, and we had 2 nurses on our team. We had a pharmacist on our team and a chaplain on our team, but our role was to conduct those difficult conversations, goals of care. What are your goals? What is the outcome? What are the wishes that you're looking for in getting this treatment? How can we serve you? What questions do you have? Do you have a comprehension of your medical condition? And if not, how can we make sure that discrepancy is bridged by communicating with the physicians and facilitating a family meeting? Some of our roles were when we had patients that were truly at end of life, but being provided life-sustaining treatments, keeping their vessel alive, but it was unsustainable. Their life was unsustainable without those life-prolonging procedures. So the goals of care was geared more towards compassionate withdrawal of those life-sustaining treatments and the care that would be provided thereafter. And as a palliative care social worker, you're setting up, getting the team involved, the primary care physician, the attending physician on critical care if they were in an ICU setting, family members, making sure all the key players are there, and identifying who in fact should be making decisions for that patient. If the anticipation is that patient's going to linger after that compassionate withdrawal, linking them with a hospice resource in the community, provide that end-of-life care and comfort measures, and then ultimately the bereavement support for the family after the death.
What an important role that is to guide that. Can you tell me what a good day? I mean, it sounds like it's a lot of emotional days. What would be a really good day that would make you feel like I had a good day today? It was a very fulfilling day for me today. What would be the best days?
I think the best days are where we've had the opportunity to speak with that patient prior to getting into crisis. And they've been able to paint the scenario of what would be my good death. And you know.
So you talk about it pretty openly.
My dad used to say, we're all born and we're not getting out of this world alive. And so we will all, pass through that journey, and it's just dependent on how. So as sure as the birth of a baby is a normal part of life, death is a normal part of life. And so my ideal day would be being able to have had a relationship with that patient prior to them getting to this crisis, and maybe being the person who has been present with them to have this transparent conversation and to implement the pertinent documents to assure their wishes are followed, and then being able to be present for that person and visually seeing that their wish was accomplished and they did have a comfortable death with whomever the people were involved and the environment that they wish to be in.
So you've worked in a hospital setting doing that as well as a community setting?
Yes, ma'am.
When you were in a community setting, were the patients on service a little bit longer than they are for a hospital, I would think? Because if they're in a hospital, you have to build the relationship pretty quickly.
Quickly. So in the community setting, I think the longest that I had a patient on services, she was on for 5 years.
Oh my goodness.
Yeah, she had small cell.
So you can receive hospice that long?
As long as you're meeting the Medicare guidelines for that diagnosis, not receiving aggressive therapies, and that she physically was showing the signs of decline.
That whole time.
That's correct.
So you probably got a really good relationship built with some of these patients that were on service for a long period of time.
Correct.
And is that fulfilling?
It is fulfilling, but it's also difficult because ultimately you do say goodbye. And like I said, the ideal day for me would be to make sure that person's wishes are followed. And sometimes family members, they're thinking with this, they're not thinking with this. And so redirecting them to, again, those written documents that have expressed, the patient has been able to express what their wishes are, and the conversations. And I use a lot when I would do family meetings, whether in the hospital, whether in a home setting, if a patient had declined to the point where they're unresponsive, I used the empty chair for counseling. And if your loved one, mom, dad, sister, brother, whomever, were here and we were talking about the what ifs of this situation, what would they tell you? So you're taking them out of the crisis and you're putting them in the past and some of the conversations that have already occurred.
Okay.
To make sure that, again, that patient's wishes are followed.
So what, and if you don't want to answer, we'll move on, but what about a worse day? What makes a day difficult when it sounds like what you do is already pretty challenging?
I think the worst day is when you've had, I mentioned, family members not being willing to honor a patient's wishes, whether they're verbally expressed or written, and observing the suffering that can occur. Because we as medical professionals, you see this person who has taken every step and done what we're supposed to do as far as writing down our wishes, and even going to the point of implementing what's called a community DNR pertaining to if a cardiac event, if I'm found down out in the community that I do or don't want to be revived. I don't want to be put on these machines. They've done everything to assure their wishes are followed, and then the family.
Okay. The family supersedes what they would have wanted.
Exactly, and I think that's the worst day, is observing that suffering that is brought on by us implementing the medical devices or treatments that we have as an evolving society that the Lord has given us, to keep that vessel alive, observing the suffering that's being forced upon the patient.
And what about a success story where you've got a family who is taking the person down the path they don't want to go? Have you had a success where you were able to get that family to kind of separate themselves from this is what I want for them to this is what they chose for themselves?
I do. I have one that it comes right back on me. I was working in a community hospital, very large hospital, as the palliative care social worker. This woman was in her 80s and on full life support as far as ventilator support, nutrition, pressors to, keep her heart rate up. She had the full spectrum. And
depended upon
everything to keep her alive, and the prognosis of recovery was poor. It was futile care, and the nursing staff would avoid the spouse when he would come in. Now this patient had a very well directed living will and healthcare surrogate designation identifying him, but everything in that living will
was being done.
Was not supposed to be done, was being done. And he came in, he was always very nasty in the sense that he would curse at the staff and again, the nursing staff would try to avoid and not get into interactions with him because of his aggressive behavior as far as verbal. He was not physical. And so my team was consulted. It was the end of the day, maybe 2:00, tour of duty. End of day for me was 5 at that time. And I spent the full 3 hours with this man, and this hostility was coming from the fact that he knew what was going on was directly against her wishes, but he didn't know that he had a voice and he could make any changes. And the transformation that was, I just let him vent my first, it was probably an hour and a half, him yelling and screaming, and these people come in and I have no control, and they put her on this and they did this, and what choice do I have? I had to say yes, I didn't want to lose her, and if there's a chance of her coming back, and just on and on and on. And as he literally exhausted his anger, then I was able to speak to him about this document that was completed, and she wasn't in stress and she wasn't under duress when she completed it, and she was able to think clearly. And did you do a form? Yes, I did one too. What good does it do? And when I finally got to the point where you are her decision maker and you can stop this at any time, it was as if he melted. and you could see the relief and the anxiety just melt away from him. So that was a success where we were able to give him the power to be the voice for this patient, which she had already given him, but he didn't know where he could intervene.
How he could do that.
Exactly. And he was able to authorize the compassionate withdrawal of those life-prolonging procedures, and she passed comfortably with medications administered to address any air hunger or whatever, and his hand in hers, and it wasn't a smile on her face because of what she had gone through, but she was peaceful. She was at rest. Yeah. And so that was a success.
A success.
You know.
Yeah. That was a tremendous, that was a huge turnaround for him.
He was empowered. He was empowered to be her advocate because they were partners in life. And that's something he just kept saying. They didn't have children. We are partners. We're partners. And now, what do I have? What do I have? How can I help her? You guys got her in this mess, in this mess. And he just kept on. And, you know, I did do some gentle confrontation that you authorize these treatments. And again, you know, you see the flare up of the anger. You know, I thought it was temporary. I taught this. And so that was a success for our patient, a success for him, you know, that he was
and that's got to be professionally very satisfying.
It was satisfying to give him his voice, to give the patient her voice, because her voice was gone, but it was still there. And he became her instrument to be able to make sure her wishes were followed.
We're getting close to the end of our time for today.
Time flies.
Yeah, it sure does. I really am just enthralled with listening to the stories that you've got to share with us today. And I'm really, really grateful and have new admiration for you. And I already had a lot of admiration for you already. I'm going to have Loloma come back again because I really want to pursue something that she led into today, which was a couple of things. One was the advance directive that she kind of introduced, but we didn't touch on. And then the other thing I want to talk to you about is that what's this difference between palliative and hospice? So we're going to talk about that in another video. But thank you for being here, and I appreciate your kind comments. Thanks, everybody.